Question number 99, atelectasis, collapse, emphysema. Now, atelectasis is defined as the complete or partial collapse of the entire lung or a part of the lung. So, complete or partial collapse of the entire or parts, meaning one lobe of the lung, and this usually occurs when the alveoli within the lungs are deflated. Now, usually the terms collapse and atelectasis are used interchangeably. However, in the Czech Republic, and for the sake of our exam, atelectasis is normally a term that is reserved for the incomplete expansion of the lungs during birth. And so in a delivery that takes place at a normal time frame and after the normal gestation period, you have sufficient amount of surfactant produced that prevents the alveolar collapse from taking place due to surface tension. However, in the case of a premature birth where you basically have pulmonary hypoplasia, you don't have a sufficient amount of surfactant produced, and as such the alveoli cannot withstand surface tension pressure, resulting in the collapse of the alveoli. And once again, you can see that the terms are used relatively quite commonly interchangeably. I said collapse many times even though we're talking about atelectasis, but yeah, the basic idea is these terms are used interchangeably, but for the sake of your examination, just know that this difference is what exists in when we talk about atelectasis and collapse with respect to the time frame on which this process is occurring. And so yes, coming back, you basically have increased surface tension when there is relatively less counteraction by surfactant, resulting in alveolar collapse in the newborn, resulting in neonatal respiratory distress syndrome. Right, now coming to how would you define collapse then? Collapse is basically occurring when you have a fully inflated or a normal lung undergo deflation due to the following pathologies that we're going to discuss. And so the first pathology in this case is the obstruction of the alveoli, which is the most common cause of alveolar collapse. Now, basically, this obstruction can be a result of a foreign body aspiration, for example. So it could be due to foreign bodies, or it can be due to heterogeneous or homogeneous masses within the lung parenchyma, within the lung tissues, that end up blocking the alveoli, and this basically means tumors. And so from the pathophysiological point of view, what basically happens is that any air that is already present, so if we're going to focus on this point, distal to this obstruction, any air that is already present in the alveoli is resorbed into circulation, and thus you may see this is also called as resorption atelectasis. Now, with no new airflow to the lungs distal to this obstruction, you are going to end up eventually, it's drawn over here, having a collapse of the alveoli. And so once again, the causes of obstruction can simply be any foreign body. It can be a tumor, or in some cases, in the cases of patients who have COPD, for example, mucus plugs forming can also be a reason. The second pathology that results in atelectasis is compression. And this simply means that you have a space occupying lesion that pushes onto and compresses the lungs, leading to air being forced out or expelled out from the alveoli, which leads to their deflation and then their collapse. As far as the causes of compression go, you can have excess fluid building up in the pleural cavity. That could be one of the reasons. And so this could be hydrothorax, pneumothorax, hemothorax, among the major ones. And basically this is what the diagram is trying to illustrate to you. Within the pleural cavity, if you have some sort of pathology that results in the buildup of fluid, you can talk about the individual etiologies to it once you learn it and the questions to follow. What this does is that this pushes onto and compresses the lung tissue, eventually forcing and expelling air out of the alveoli and resulting in the collapse of the lung, depending on what part of the pleural cavity is actually filled with fluid and to what extent it's filled with fluid. This could be either a complete collapse or a partial collapse of just a lobe, for example. The third type of atelectasis associated with pathology is contraction atelectasis. This is normally seen in interstitial lung diseases and progressed interstitial lung diseases where you have significant amount of lung fibrosis. And so this is a morphological change that you need to be careful with, so I'll just highlight it. As a result of lung fibrosis, you can imagine that there is a decreased airflow into the lungs. This is normally what is characteristic of restrictive lung diseases as compared to obstructive, where you have troubles getting the air out. And so with all of this fibrosis, with all the parenchymal scarring, you basically have contraction of the lungs, as fibrotic tissue will contract. And this in turn expels any air that is already present in the alveoli. So that's one thing. But what fibrosis also does is that it prevents the expansion of alveoli as well. And so as a result, you have alveolar collapse. And so causes of contraction atelectasis are once again interstitial lung diseases, can be tuberculosis, could be sarcoidosis, among others. Fourth type, which is something we've already discussed, but we have to discuss it separately as part of it being a pathological process in adults, for example, is basically is the adhesive type of atelectasis, and this is simply where you lose surfactant, as we had, and then everything that happens is as we discussed in the case of a newborn. So loss of surfactant results in increased surface tension, which as a result causes a collapsed alveoli. And the most common cause of this is normally seen in acute respiratory distress syndrome. So atelectasis can also occur due to acute respiratory distress syndrome. So once all of this is happening, what are some of the morphological changes that we can see at the level of the lung and some of the complications associated with this? So take this lung which is undergoing atelectasis, and you can see that you have an overall decrease in lung volume and size, and so you have a smaller appearing lung as far as morphology goes. And the complications of this include any chances of superinfection. So infection, it can lead to hypoxemia occurring secondary to a VQ mismatch, because again you're not ventilating the alveoli, and so what this means is that the blood supply has to be diverted to other parts, to other alveoli that are relatively well ventilated, and so you have pulmonary capillary constriction. Once you have that, you increase the risk of pulmonary arterial hypertension, which increases the risk of cor pulmonale, which is right-sided heart failure. Another complication is that if you have a lot of fibrosis of, if not a lot, but like in case fibrosis takes place while the lung is collapsed itself, or the alveoli is collapsed, this process is then irreversible, and so that is the loss of your alveoli as a whole. And that basically summarizes atelectasis and collapse together. It's a very easy concept to understand. There's not a lot much to it, and you should be able to answer. As long as you're able to talk about these things, you should be completely fine. Now, moving on to emphysema. Emphysema is the second part of this question, and it is just defined as an obstructive lung disease that is characterized by a pathologically increased amount of air in the lungs occurring secondary to a loss of alveolar elasticity. The two etiologies that are associated with emphysema are alpha-1 antitrypsin deficiency and tobacco smoking. And so just a brief overview on the pathophysiology of alpha-1 antitrypsin deficiency. It is a genetic condition that is characterized by defective or missing alpha-1 antitrypsin. Now, alpha-1 antitrypsin is a protease inhibitor that inactivates elastase, and this alpha-1 antitrypsin is produced by the liver. Once it's normally when you have some sort of infectious etiology or any sort of damage taking place to the lungs and acute inflammatory cells, being your neutrophils, once they're in the alveoli, they release an enzyme known as elastase, which breaks down the elastic fibers that are found surrounding your alveoli. And so if these elastic fibers are broken down, you can imagine that the functionality of the alveoli, the ability of the alveoli to recoil and push air out, is completely lost. And so to prevent this, you have alpha-1 antitrypsin, which inactivates neutrophil elastase. And so if alpha-1 antitrypsin is missing, this process is completely halted. So with alpha-1 antitrypsin deficiency, elastin can be broken down, and you can see panacinar emphysema. You increase the risk of chronic bronchitis, and you increase the risk of bronchiectasis. Another etiology of emphysema is tobacco smoking, which damages the alveoli and the elastin fibers of the wall directly. So just don't smoke. And now we need to talk about what happens as far as morphology is concerned. And what's going to happen is that when you have destruction of the alveolar walls and elastin, so destruction of walls plus elastin leads to the formation of acini or singular acinus, which has a relatively decreased total surface area for gas exchange as compared to your regular alveoli. And so now the next thing we need to talk about are a few terms that are associated with emphysema. And to know this, you need to be a little bit aware of the respiratory tree. Remember it from anatomy. If you don't, I have it just laid down. The simple bits that we're going to be discussing laid down over here. And with this, we're going to discuss the distribution of emphysema. So you've got respiratory bronchioles, which leads to alveolar ducts, which leads to the alveoli. Now, if the breakdown of elastin and the walls are occurring at the level of the respiratory bronchioles, so at the level of the respiratory bronchioles, we call this centri-acinar emphysema. If it's occurring at the level of the alveolar ducts and the alveoli, we call this distal acinar. And if this breakdown process of the elastin that surrounds these alveolar walls occurs throughout this portion of the respiratory tree that we've discussed, the respiratory bronchioles, the alveolar ducts, and the alveoli, the term that we use is pan-acinar emphysema. And so just so these terms are cleared out for you. So we've got one centri-acinar emphysema. Emphysema. Oh my god. Right, so centri-acinar emphysema more commonly involves the upper lobes of the lungs, meaning that it is the respiratory bronchioles that are more likely to undergo damage and lose their elastin fibers surrounding their walls. And these respiratory bronchioles are the ones that are more commonly found in the upper lungs. And this is most commonly caused due to smoking. And it's quite easy to imagine that smoking results in damage at the upper lungs because smoke rises, right? Simple stuff. Pan-acinar, the second type, meaning that the entirety, the respiratory bronchioles, the alveolar ducts, and the alveoli are all affected, and all of them have a loss of their elastin fibers and damage to their walls. This normally occurs more commonly in the lower lobes, and this type of emphysema is the one that is more commonly associated with alpha-1 antitrypsin deficiency. And all you need to know as far as distal acinar is concerned, it can be caused by both smoking and alpha-1 antitrypsin deficiency, but the damage takes place more likely to the alveoli that are found closer to the pleura. So close to pleura. Right? Now, what is the complication of not having elastin present? Without any elastin fibers present, because they're broken down by the processes we just described, the alveoli loses its ability to recoil and push air out when you are exhaling. And so this results in air trapping within the lungs. So what are some of the morphological changes that we can see in association with emphysema? The first one is that because of all the destruction taking place at the elastin and at the alveolar wall, you have a loss of alveolar septa. You have enlarged air spaces. And you may have deformed or collapsed bronchioles. Patient presentation, as far as you will need to be able to differentiate a patient who has COPD with a patient who has emphysema. Both are obstructive lung diseases, but for an emphysema patient, we can see that they have pursed lip breathing, These patients are relatively normally thin, and they have a barrel chest, which basically means they have an increased anterior posterior diameter. Complications that are associated with emphysema are actually quite simple. You think about it, if you're overfilling the lungs with a lot of air, you can have the formation of these air bullae or blebs, which can essentially end up rupturing, and this will then lead to pneumothorax. And so that is one of the major complications of emphysema, along with the fact that you have a lot of VQ mismatch, a lot of issues with exchanging air, getting air out of the lungs. And yeah, so this is basically the entire question. This is a very short question, a nice question to get. And if you talk about all of these morphological changes along with the definitions and for the most part the pathophysiological process, you should be good for this question. That's it.